It's time for the Health Links podcast, where we engage in conversations that promote healthier living. I'm your host, DJ Thatcher. In this episode, we're coming to you from the offices of Lowcountry Orthopaedics and Sports Medicine. And our topic today is on some new techniques and new options when it comes to hip and knee replacement. So if you're a practitioner who has some patients that might benefit from this, or if you're a layperson, as most of our audience is, and you or maybe a loved one is experiencing some of these problems, pay attention. We're joined by Dr. Neal Huang, who is a fellowship-trained hip and knee replacement surgeon with Lowcountry Orthopaedics and Sports Medicine. Dr. Huang, welcome to the Health Links podcast.
Hi, DJ. Thanks for having me.
Absolutely. So before we get into some of the specifics about the new updates and new procedures and so forth for these conditions, give us an overview of just the prevalence of hip and knee replacements. It seems like we're seeing more and more all the time, and I'm wondering if it's because we're just getting better at diagnosing these conditions, or if we as people are just beating ourselves up more than ever. I don't know. What's the answer there?
Yeah, you make a really astute observation. We are seeing more patients who are needing hip and knee replacements. Mm-hmm. It's actually a number of factors. I think the biggest reason is a generation, right? Baby boomers, huge generation.
Sure.
And they're all reaching the age of 60s, 70s. Mm-hmm. And the difference between baby boomers and previous generations is that they're a lot more active. We see a lot more baby boomers who want to play sports, visit grandkids, go on trips, and just be more active in life. And they want to be present and continue, doing the things that they love doing.
Yeah.
And I think with that, you have the intersection of joint replacements becoming better and more functional, and it meets the demand of these patients.
Sure.
So with that, you kind of see an exponential rise in people getting hip and knee replacements.
Get it.
And why probably most people on this podcast either know someone who's had a hip or knee replacement or have had one themselves.
Now, a lot of people, I guess, as they age, they just figure, hey, I'm going to have more, aches and pains and decreased mobility. What's the tipping point for someone to say, hey, this is really a problem. I need to see someone.
Yeah.
And who should they see?
Sure. That's a great question. I get asked, that question all the time about when is the right time to get a knee replacement or a hip replacement. And it kind of boils down to, in my mind, three main questions that the patient should ask themselves. Does it bother them every day?
Yeah.
Does it keep them up at night? And does it stop them from doing the things they want to do?
Okay.
If they're saying yes to all three of those things, I think it's reasonable to seek the care of someone for their joint pain.
Yeah.
Ideally, if you're over the age of 55 and you're having issues with your hip or knee, it's reasonable to seek the care of an orthopedic surgeon, likely a joint replacement surgeon, simply because the most common cause for hip and knee pain after age 55 is arthritis.
Okay.
Now, it's not to say that that's the only cause for pain. And, as a joint replacement surgeon, I specialize in not only surgery, but also non-operative care as well. So how can we get you the most functional and least painful to continue living your life, whether that's with injections, medications, therapy, ice, bracing, or is it with surgery? And that's something, I really walk through with each of my patients to kind of explore those options.
Gotcha. What are some non-invasive procedures that you might recommend first before going to surgery? And there's physical therapy and other things, anything that can really help or at least maybe prolong the need for surgery? Absolutely.
I think, the mainstay for treatment is medications. Mm-hmm. So anti-inflammatory medications. There's a lot of good anti-inflammatory medications out there over the counter, but there's also some stronger ones so you can get prescription strength.
Sure.
Right? So that's always kind of choice number one, lowest hanging fruit. Next option, like you mentioned, physical therapy to strengthen and stretch the joint, build the muscles around the joint so that you're not having to rely on the bones rubbing against each other to get motion themselves. You may be able to leverage a little bit more musculature to help get you moving. And the third option, I think, that is very common and very easily achievable that can have very profound results for joint pain are injections. Mm-hmm. And I go through this with my patients. There's multiple injections out there. There's all these different advertisements and different kinds of companies out there that are offering everything under the sun. And it can be confusing. So a lot of the time I spend in my clinics educating patients on what injections are available, what are the risks and benefits, what is the research support, and what can they expect based off of their current course of their arthritis.
There's this huge industry there with nutritional supplements, and along with that, a lot of YouTubers and others who are really promoting metabolic health as well. What's some of the fact and fiction when it comes to whether it's nutritionals or some of the diet and metabolic changes that we can make? Anything there that can really help with joint issues?
Right. So, there's a lot of sensational things out there or anecdotal evidence, meaning I did this, it worked for me. And, whether or not that is because of what you did, or is it because arthritis has a natural course of pain that gets better, gets worse on its own? We don't know. I think what's safe to promote and to recommend is a healthy Mediterranean diet, low inflammatory, avoiding processed foods, eating whole foods, having a well-balanced protein diet is very important. And there's been some research to show that low inflammatory Mediterranean diets can help alleviate some pain. Obviously, weight loss ties hand in hand.
Sure, yeah.
The hip and knee experience, multiples of our body weight as force going through it based off certain motions. So,
for stairs and things like that, a tremendous amount.
Absolutely. So, when you do stairs, for example, 6 times of your body weight goes through your kneecap.
Wow.
Motions. So, that can be quite painful, right? So, if you gain, let's say, 20 pounds, that's 120 pounds of force going through that kneecap per step. And then, it may be lower the multiple when walking, but still, that adds up to thousands of pounds of force throughout a day, right?
Wow.
So diet can definitely help with that, not only for anti-inflammatory benefits, but also for weight loss. As far as supplements, there's not been a whole lot of peer-reviewed head-to-head research articles that have shown supplements really moving the needle very much. Now, I'm a big proponent in, whatever works for the patient, right?
Sure.
It may not make sense, or we may not know the exact mechanism, but as long as the patient feels better and it's not causing any harm, I'm okay with it. So, different supplements, people like to try turmeric. That's a reasonable anti-inflammatory supplement to try. Fish oil, if appropriate. And these are all just things that are anti-inflammatory can help. So it's a discussion I have with my patients, and we definitely can go more into depth with them, in clinic. But I think there's some role for that for sure.
Sure. Obviously, your specialty is the surgery. Do you find today, with many patients being able to self-refer to different specialties, do you find that people are reluctant to come to you as a surgeon? They might think that, if I ask a roofer if I need a new roof, they're going to say yes.
Right.
They might have that same thought with going to a surgeon. They're going to recommend surgery all the time. What would you say to those patients, or what are the steps you go through when you evaluate someone?
Yeah, for sure. I think, that's a legitimate concern, right? Yeah. And like you said, with a roofer, you're going to get a new roof. For sure. As a joint surgeon, I think it's more depending on the doctor, right? And the reputation. Are they someone who operates on everyone who walks through the door, or are they listening to what the patients have to say and teasing out who does well with surgery and who doesn't? I think a big component of patient outcomes for a surgeon is not only doing the surgery itself, but it's deciding when to do the surgery, right?
So that's what I was wondering. What's that tipping point?
Right. So a lot of that's kind of the art of medicine, and as a surgeon is determining, who will benefit from it. Do they understand the risks and benefits? Because everyone's risk-benefit profile, one, is different going into the surgery.
Sure.
But also, two, your tolerance for the risk as a patient may be different from person to person, right? Your demand as an active, person in their 60s, playing sports, hiking, your risk for, or your tolerance to risk may be lower than someone who's bedbound and in extreme pain.
Sure.
Arthritis, right? So I treat the whole gamut of patients, from the healthiest to some of the sickest. And it's a different discussion, but, my job is to guide and inform my patients.
Okay.
Right? If surgery is the right choice, where we think that would provide them the best outcome and have the most improvement in their quality of life, then we talk about it. Okay. If I think non-surgical interventions makes more sense, then we stick with that.
Okay, good. Yeah. Well, thank you for that background information. So now getting into the heart of our discussion today, which are some of these newer advances, and the hips and the knees, the two biggest joints in the body, I guess, right? So let's start with the hips. We'll work our way down. So with the hip replacement, you now have this new technique called the bikini anterior hip replacement. And very intriguing name. What's that all about?
Yeah, so it's kind of a cosmetic approach to the anterior hip replacement.
And that's in the front, the anterior, right?
Yeah.
Right.
So there's been a lot of debate back and forth in the past 20 years between surgeons about anterior, posterior, or side. And there's been varying amounts of research and literature to look at that. I think after the past 10 years, it's pretty safe to say that with the anterior approach, you have a quicker recovery. You have less risk of the ball popping out of the cup.
Okay.
You have more accurate implant positioning because we use X-ray.
Okay.
All that adds up to faster recovery, basically, and less pain compared to traditional surgical approaches.
Sure.
Right. The bikini incision is just the next iteration of that technique, where we make it even more cosmetic. So a traditional anterior approach, which I do fairly often, is a vertical incision down the front of the thigh. It's a thin line, but it's vertical. And bikini approaches, we kind of take that incision, turn it about 90 degrees.
Okay.
So where it falls into the crease of your skin, the natural lines of your skin.
Gotcha.
So it almost disappears. And it can be very difficult to see after it heals well. I offer that to patients who are appropriate in body size and habitus, and for people who care, right? Some patients are a little bit more concerned about the cosmesis of their incision. And that's just definitely a good option to offer.
Okay.
The procedure itself is still the same, but it heals just a lot nicer.
That's nice. The hip, by the way, I guess we should have covered this in case any of our lay public is not aware. It's the thigh bone, top of the thigh bone, or the femur, and that head is fitting into a part of the pelvis. Is that correct? Right. So it's not the way up here. It's that hip down the joint right there.
Yeah. So a lot of times patients come to me with hip pain. They're pointing to the backside of their thigh or the outside.
Right.
The hip joint itself, like you said, is a ball and cup joint made up of your thigh bone, the femur, your pelvis, the cup. When people start having pain, 9 times out of 10 they'll experience groin pain.
Okay.
And, they often come to me and say, I thought I pulled something, but it just hasn't gotten better. And we take an X-ray and it's severe arthritis. Hip pain definitely can come, down there in the front groin area, but it can also show in different ways as well.
Interesting.
Yeah.
So walk us through the surgery. This is an all-day surgery, it sounds like, or it's what's the time frame? What's the recovery period like?
Yeah, so that's a good question. The actual surgical time in my hands has really improved a lot. I've trained with some of the most efficient surgeons in the world.
By the way, where did you train? It's out to our audience. Yeah, we want to highlight you too.
Sure. Yeah. So I did my medical school at the University of Texas in Houston.
Okay.
And I did residency in the University of Tennessee in Chattanooga. I did my fellowship in Atlanta with total joint specialists. It's a world-renowned.
I was going to say pretty famous place.
World-renowned joint replacement, focusing on complex revision as well as high-efficiency outpatient procedures. For joint replacements. And I was able to glean, a little bit off those giants and bring it here to Charleston.
Terrific. Yeah, just a year and a half ago or so you've been here, something like that. Yeah.
So we've had great success, and a lot of people come to see me for that.
You're great.
But as far as the time it takes for a joint replacement, I would say, in my hands, a standard knee or hip replacement takes about 35 to 40 minutes.
Wow.
And then you get up and walk the same day. Actually, shortly after surgery, my preference is a spinal anesthesia.
Okay.
I have a lot of patients come to me with concerns about having that brain fog or severe nausea after general anesthesia, which can happen with gas. So we try to avoid that with spinal anesthesia to get your legs numb, and then when you wake up, you're ready to go.
Sure.
So that helps aid in pain control and helps you get up and move quickly.
Are patients reluctant to do that? I know they're educated ahead of time, but within a few hours of surgery, they're actually walking.
Oh, yeah. Sometimes less than an hour.
Wow.
And we have them up and walking, and we have them do stairs, and they go home the same day.
Wow.
So I would say...
Amazing.
Yeah. In my practice, we probably have 90 to 95% same-day discharge of elective joints.
And they're getting physical therapy and so forth at home, I imagine.
Correct,
And what's the total recovery time till they're back to, well, not their baseline, because we want it to be better than their baseline, right? What's that look like?
It varies. I would say for a hip, most of my patients come to me at 2 weeks after surgery with just a cane or nothing.
Oh, wow.
I would say that's a standard for a hip replacement. Hip replacements recover much quicker than knee replacements. It's kind of across the board. I tell every patient, and people watching this can probably attest to it who's had both. A hip replacement is probably 3 times easier to recover from than a knee.
Okay.
Right? But with a hip replacement, I expect pretty rapid recovery and exceeding their preoperative state almost immediately. I've had a number of patients tell me that their pain was better waking up from surgery than it was before surgery, which is kind of the miracle hip replacement.
So let's move down to the knee. Yeah. Why is that more difficult? Because that is the biggest joint, I guess. Is that why, or has the most weight, or what's the reason there?
I think the knee is just slightly more complicated of a joint. I think for one, it's much more superficial.
Okay.
And it's very sensitive to any kind of swelling. right? The hip joint's kind of buried deep in your body. It's not as sensitive, but the knee has multiple planes of motion. It's right there. If you have any swelling, you really feel it. And the knee is much more of a soft tissue procedure, in my opinion, than a hip replacement is. Hip replacement, you kind of take out the bones and you put in the metal, you're done. The knee, you have to respect the soft tissues. You try to not aggravate the balance of the knee too much doing the procedure, and you have to get that all done quickly.
Okay.
So that's why I think the knee can be difficult. Now, I would say with the kinematic technique that I've been using, the recoveries are kind of approaching hip replacements. With what I'm seeing, patients are coming to me at the 2-week mark with, I would say about 2/3 of my patients have minimal pain, minimal swelling, good motion.
Interesting.
With either cane, sometimes with no assist devices.
Yeah.
But most of them come in with a cane at 2 weeks, and then some come in with a walker, but quickly get off of that.
Okay. So back up just a moment, because I know you have this kind of a wordy title called a personalized kinematic total knee replacement. I think we've heard of total knee replacement. Yeah. What's this personalized kinematic aspect?
Yeah, so it's kind of the latest iteration of knee replacement. It's more of a philosophy about how you put your implants into the body.
Okay.
And just roughly speaking, traditional knee replacements done maybe 15, 20 years, the goal was to put it in what's called mechanical alignment, where you're making the bones perpendicular to the ground.
Okay.
And that's thought to give it better stability, give it better longevity. Recently, in the past 5 to 10 years, there's been a surgeon out of California who initially invented this procedure called the kinematic technique. And the idea is you respect the soft tissue and the shape of the knee.
Okay.
Meaning you don't change the shape of the knee. You try to preserve it as closely as possible to give the patient a functional knee. So between you, me, a 75-year-old woman, 85-year-old man, smaller person, bigger person, everyone's knee shape is kind of different, right? So the idea that we used to put knees the same in everyone didn't really make sense, right? So what surgeons ended up having to do was releasing ligaments or soft tissues, or adjusting the bones to put them in a certain position to make it fit properly. Whereas kinematic technique, you're just taking off however much bone and cartilage you're replacing with metal and plastic.
I see. Okay.
So that way you're maintaining the shape of the knee. There's less soft tissue disruption and a quicker recovery.
Okay.
And that's kind of bearing out in the literature. Like I said, this technique's only been out for about 10 years.
Okay.
And the research shows that it has a quicker recovery, the higher forgotten joint scores, and the longevity of it is just as good as the standard traditional.
Well, what percentage of knee replacements you're doing now are this newer personalized kinematic approach?
100%.
100%. Okay.
100% of
why you're doing it. Okay.
Yeah, 100% of my primary needs are
I got you.
kinematic approach.
Okay.
Yeah.
So what if someone comes in and they have both a hip and a knee issue?
Sure.
They both need to be replaced. What do you start with?
It's a good question. So I see that not infrequently.
I bet.
It's more of a discussion with the patient, honestly, to see which one's bothering them more. If all things are equal, I often recommend the hip first, just because, like we talked about earlier, it's easier recovery.
Yeah.
That way you can kind of get on your feet, kind of dip your toes in the joint replacement world and the knee. But it mostly depends, right?
Okay.
Because sometimes people have maybe mild arthritis and severe knee arthritis, or vice versa, and that discussion becomes different. But it's more personalized. But if all things were equal and they're both severe,
Yeah.
I see the biggest and quickest gain in function and quality of life with hip replacement.
Do you find that in most people you end up doing both sides, or is it individualized? I mean, some people just need a one-sided replacement.
Yeah, I definitely have my fair share of repeat, both sided customers. I would say that it just depends. Some people need a knee replacement because they had an injury.
Right.
Some people need a knee replacement because of genetics, or they have abnormal, shape of their bones or something. And that can be dependent on whether or not we need to do one or both. But really, at the end of the day, it depends on what the patient tells me. Because I have plenty of patients who come to me with severe arthritis in both hips or both knees, and we fix the painful one. They're saying, "Doc, the other side feels fine." And
interesting.
We leave that alone,
Okay.
My goal is to listen to the patient and kind of make them the most functional and least painful as possible with the least amount of intervention. So if that means surgery on one side and leaving the other side, that's fine. We don't.
If I come to you and I need both, Can I get them both done at the same time, or what's the time frame between the two?
Sure. I prefer not to. Just it's a lot of surgery overall for one person to go through one day, especially for knees. The recovery it can be pretty involved, and I really want them focused on that.
Okay.
Your outcome is heavily dependent on your ability to rehab, especially for a knee replacement. For hip replacement, not so much. It's just more of a concern for blood loss and time under anesthesia and things like that.
Okay.
So I prefer to do them one at a time.
Gotcha.
The quickest I do back-to-back joints would probably be 6 weeks.
Okay.
For hips or knees. I do have a fair share of patients who we do that for because, like I said, 2/3 of my patients come to me at very high functioning levels after a knee replacement, so they're ready to go pretty quickly.
Gotcha.
Hips, yeah, definitely 6 weeks if they're having a standard hip recovery.
Understood. What if I had a replacement done years ago and I'm not happy with it for whatever reason?
Yeah.
Are you seeing those types of patients coming in, they want to redo it or get a new replacement?
Yeah.
What's the prevalence of that?
Yeah, I definitely see that. That's a growing amount as well.
Is it? Okay.
Patients out there.
Okay.
Simply because of math, there's a certain percentage of hip or knee replacements that need revision or have issues. And with the number increasing of people having these procedures done, there's going to be an increase of people who have unhappy joints. And
Sure.
I'm always happy to see those patients, evaluate them, give them a second opinion, and see, hey, can we make this better? Is that with less invasive techniques like bracing or physical therapy or nerve stimulator, or do we need to look more aggressively into ruling out infection, ruling out for loosening, or seeing if we can make it more stable somehow? It can be quite complicated in the revision hip or knee world, and it's more individualized for sure. Based off what the patient is dealing with, their symptoms, their history, we walk through that process and explore that together.
I'm sure you've noticed now in your almost 2 years in the South Carolina market, it's not always the healthiest population we have here. I know we lead the country in many areas. Who is not eligible for this type of surgery, even if they have bad joints? People with, I'm thinking somebody with atrial fibrillation on blood thinners and morbidly obese or something like that. What are some types of patients who you either need to say no to, or it's yes, but you need to do this first?
Yeah, I think the yes, but category is much bigger than the purely no category.
Okay, that's good.
In our literature and research, there's a lot of different risk factors that can increase your risk for certain complications. Being on a blood thinner, for example, having excess weight, being diabetic, having kidney disease. These are all things that can increase your risk.
Right.
Now, it's not to say that you're definitely going to have a problem, but I think it's important to understand, hey, your risk, DJ, for infection may be 5%, whereas in a perfectly healthy person, it's less than 1%.
Okay.
Are you willing to undergo that risk? What does that risk look like if we run into that problem, right? So I like to have that discussion with my patient about whether or not, we should proceed. Now, there are certain things we can control, like weight, sugar control, smoking status. Those things I'm more hard and fast on, hey, we got to get this better before we proceed with the joint replacement to position ourselves for the best outcome possible.
Okay.
You really only have one good shot at a joint replacement.
Okay.
And you want to make sure that you take your best shot.
Makes sense.
If you have an uneventful recovery with no complications, you have a very high chance of doing well and having 10, 15, 20 years and more with the joint, right? Or the rest of your life even.
Sure.
Whereas if you run into complications early, you may kind of fall down this rabbit hole of more surgeries, multiple problems, and you're kind of chasing your own tail. So we really emphasize preoperative optimization. Some patients truly are just too unhealthy. They can't get clearance from their heart doctor or primary doctor. In those cases, you do your best to do some kind of palliative injection, medications, therapy, bracing to get them by. But that's kind of few and far between. Medicine has come a long way for a lot of chronic disease conditions.
Absolutely.
And we're getting better and better as surgeons, as anesthesiologists, as health systems, in dealing with these sicker patients.
Well, and as we finish up, that's one thing I'm asking pretty much anyone that I interview. How has technology, and in particular artificial intelligence or AI, how is that affecting what you're doing? Is that pretty prevalent in orthopedic surgery these days, or what?
Yeah. I think it's starting to emerge in the technology side of things. It hasn't quite touched the surgery, the OR room yet.
Okay.
It's still very much in its infancy. There's a lot of companies looking to get into that space and trying to test technologies. We just don't know how much it's going to impact it or what the impact will be yet.
Terrific.
But it's just starting.
Understood.
Yeah.
So we've been discussing the latest techniques and technology that's emerging in hip and knee replacement surgery with Dr. Neal Huang with Lowcountry Orthopaedics and Sports Medicine. Dr. Huang, thank you so much for joining us on the HealthLinks podcast. Thank you for joining us for another episode of the HealthLinks podcast. And remember to follow us on YouTube, and we'll put that link down below here. Again, I'm DJ Thatcher. Thank you for joining.